Well, good morning, all. I'm Dr. Laura Leacher, and welcome to today's Medical Grand Rounds. Per usual, we will get started with some logistics and then introductions for today. Please be sure to join us for next week's very special CAMR lectureship. It will be the talk From Evidence to Impact, Lessons from Landmark Diabetes Trials Shaping Tomorrow's Care, and that'll be given by Dr. Radhika Basui. Grand Rounds is a collaboration between Providence St. Vincent and Providence Portland Medical Center. We are almost always here live in person on Tuesdays at 8 a.m. in Southern Auditorium at St. Vincent's. We are sometimes live at noon, also on Tuesdays at Providence Portland in their auditorium. Next week's speaker will be live at both locations. You can always find out where Grand Rounds will be occurring by the weekly invite. And you can also use the weekly invite to open a link to watch a recording of Grand Rounds. You can earn CME credit for being here in the room, for watching live virtual on Teams, or by watching the recording. And I'll be monitoring the Q&A throughout the session for those of you joining us on Teams Live. Please go ahead and post your comments and your questions, and I will mostly hold those as time permits at the end. And now it is exciting to introduce not one, but two fantastic speakers and clinicians. We are joined by Dr. Roma Moza, a practicing hospitalist physician. She earned her medical degree from Ohio State University and completed residency at Baylor College of Medicine. Dr. Moza joined Providence in 2018 as an internal medicine and pediatrics hospitalist, and certainly has become well known for her excellent care and clinical teaching. Dr. Goldstein is also a practicing hospitalist, as well as Associate Program Director for the Providence St. Vincent Internal Medicine Residency. He earned his medical degree from Keck School of Medicine of the University of Southern California and completed residency at our very own Providence Portland Medical Center. Dr. Goldstein has been active in many leadership and education positions in his time here, including most recently course director for our point of care ultrasound curriculum. Thank you so much, both Doctors Moza and Goldstein, for joining us today.
All right. Well, I have the distinction of being able to kick us off in this updates in hospital medicine. Hopefully, I will leave Dr. Roma plenty of time for her side of this thing. So I just warned her as I was practicing last night. Hopefully, I don't run over too far on my side. But first off, the all-important disclosures, we have none, although I'm always looking for opportunities to get paid to do things I love. So if you have ideas afterwards, come and find me. I'm sure Dr. Moza would share the same sentiment. So learning objectives today. Well, we want to give you a good overview of some important updates over the last couple of years. We're going to review recent clinical evidence and updated practice guidelines relevant to hospital medicine. Want to help you understand the practice management decisions that impact the transition of care from hospital to home for our patients, and hopefully appraise the evidence presented within the construct of whether the information is practice changing, practice affirming, or practice questioning. The way we're going to focus on this is with some clinical vignettes, but we're also going to take it through the lens of a day in the life of a hospitalist, although hospitalist in different roles. So at this point, we have swingists, we have nocturnists, we have admitters, we have rounders. So each of these will have a little bit of a different flavor, but hopefully give you a feel for what it's like to live the life of a hospitalist inside the hospital these days. So to kick things off, you walk in refreshed and ready to jump into the day ahead. And this is ChatGPT's version of I guess, a happy hospitalist going to work. Looking refreshed. Our first case today will involve antibiotic selection, so bugs and drugs, and this is our randomized controlled trial adventure that when I asked for a superhero whose superpower is randomized controlled trials, this is what ChatGPT gave me. So case one, so you're the triage hospitalist in this case, and you're getting called by the ED to admit a 70-year-old male with a past medical history, diabetes, hypertension, CKD stage 2, comes in with chief complaints of fevers, rigors, body aches. The ED provider tells you that on review, they didn't really have any localizing symptoms for that, where they are worried this infection could be come from. Specifically, nothing like cough, shortness of breath, dysuria, abdominal pain. They got the all too common chest x-ray, which was unremarkable. Vitals, patient's initially hypotensive, 89/50. has an elevated heart rate of 105 and they're febrile. Labs show that they do have a leukocytosis of 18,000. Lactate, fortunately, is bumping up against the upper limit, but is normal. And the complete metabolic panel is also normal. And of course, blood cultures are drawn. In the ED, they give the patient their 30 cc per kilogram bolus of LR. Blood pressure does improve, and the patient received Vanco and Pip/Tazo in the emergency room. So you're on triage and you know that it might be a little time till someone can come down and get this patient and see them and make further decisions. So you decide to initiate some holding orders. And the question for you to think about is, which of the following antibiotic combination do you select? Do you go with what the ED started? You know, they gave them vancomycin, very broad. Or maybe you choose vancomycin. You remember some articles earlier on that talked about maybe some renal compromise that can happen if you combine Vanco and Pip/Tazo, and this patient has some chronic kidney disease. Maybe you want to go a little bit more narrow. Maybe you're worried about some resistant organisms, so you reach for Vanco and meropenem. Or maybe you don't want to risk the AKI, but you also want some anaerobic coverage, so you reach for vancomycin metronidazole. All these are broad selections. But what I want to talk about a little bit today is the dilemma we often face when we're choosing broad spectrum antibiotics in a patient with undifferentiated sepsis. The decision between Vanc and Zosin. These are two very common antibiotics that we have available to us to choose with pretty comparable effectiveness, pretty comparable spectrum, similarly effective against anaerobes that both add, or not anaerobes, but antimicrobial resistance, and they also add pseudomonal coverage. But some years ago, there was a fair amount of talk about the risk of AKI with vancomycin and Pip/Tazo as a combination. And then more recently, as there has been a shift a bit towards cefepime, we've seen more neurotoxicity come out of cefepime, which is really a class effect of beta-lactams, but there seems to be a stronger signal with cefepime. And then finally, you know, Pip/Tazo does have the one spectrum advantage or potentially disadvantage that it does provide anaerobic coverage, and sometimes maybe less is more. Maybe there's some harm that could be associated with that. So there's two articles I'm going to review today on this topic. One is the ACORN trial, which was a recent randomized clinical trial comparing cefepime and Pip/Tazo in 2023, and then this more recent article just last year looking at mortality in sepsis when patients receive cefepime versus Pip/Tazo. So to start with the ACORN trial, this was a randomized single center open label trial that was done at Vanderbilt. They enrolled 2,000, roughly 2,500 patients hospitalized with acute infection. So this was kind of the spectrum of illness, not just sepsis. And they were enrolled at the time of presenting to the ED or to the medical ICU. And the intervention here was to provide a patient either cefepime in one arm or Pip/Tazo in the other. The primary outcome that they looked at was the highest stage of acute kidney injury. So this article is really trying to focus on whether or not there's truly a risk of acute kidney injury and providing Pip/Tazo and Vanco. But they looked out to 14 days and they ranked people on an ordinal scale. So 0 being survived their hospital or their 14 days without AKI, or 4, which is death. And then stage 1 through 3 are just varying levels of kidney injury. And then the secondary outcomes, one was incidence of major kidney events by 14 days, which was a composite between death, new kidney replacement therapy, or a final creatinine at 14 days that was double their baseline. And then the other secondary outcome was alive without delirium. So this is a nod towards the neurotoxic effects potentially of cefepime. So delirium is measured by CAM or decrease in mental status or coma as measured by a RASS of 4 or less. And so what did they find? Well, contrary to what the earlier observational studies that were done in around 2017 that showed potentially an increased risk of acute kidney injury, this study did not find any difference in renal outcomes between cefepime and Pip/Tazo, and this was durable whether or not the patient received vancomycin. And you can see here I put a little asterisk. This is the forest plot. To the right favors Pip/Tazo and to the left favors cefepime. And you can see based upon the breakout of all the subgroups, really nothing favored one antibiotic over the other. And here's vancomycin, of which about 77% of people received both the vancomycin and the other antibiotic. There was really no signal there. What they also found, though, was cefepime was associated with some neurological side effects, although a mild hazard ratio there, but there was a detectable signal. So ultimately, I don't know that this tipped the scales one way or the other for the antibiotic, but I think it does help reassure that there's probably less of a concern about renal outcomes between those two antibiotics. So let's pivot to the next article that compared mortality outcomes with Pip/Tazo and cefepime. So this was published just last year. It's a retrospective cohort study. It was a single center out of University of Michigan. They did something called an instrumental variable analysis, which I'm not going to get into, partly because I don't fully understand how this works. It's some statistical magic. But basically, it was centered around the fact that we had a Pip/Tazo shortage around the year 2016 that created a kind of natural experiment where in this center they had to use cefepime over Pip/Tazo. And they felt through this instrumental variable analysis could try to replicate a randomized control trial. Population was about 7,500 patients presenting with undifferentiated sepsis admitted from the ED. They excluded infection areas that would likely predispose you to wanting to use one of the antibiotics over the other. So either anaerobes with necrotizing HENT or intra-abdominal, or you'd probably want to use cefepime or cephalosporin if you had a CNS infection for better penetration. The intervention here was Pip/Tazo plus vancomycin versus cefepime plus vancomycin. And then the outcomes were pretty strong outcomes here. So 90-day all-cause mortality was their primary, and secondary outcome was organ failure-free days, so not requiring vasopressors, mechanical ventilation, or dialysis. And this just shows you this instrumental variable, what they used here with the Pip/Tazo shortage. So you can see that the prescribing habits flipped just because they didn't have Pip/Tazo, but clearly they use Pip/Tazo more often than they use cefepime. But there was this year period there where their usage pattern flipped. So what did they find? Pretty amazing results, I actually thought. So the 90-day mortality, if you look at the Pip/Tazo folks, was 22.5% versus cefepime was 17.5. That's an absolute mortality increase in the folks who received Pip/Tazo of 5%, and these were statistically significant. And then the organ failure-free days, which I try to get my patients as many of those as possible, there was 2.1 fewer organ failure-free days, so that's bad, in the Pip/Tazo arm versus the cefepime. And again, that was statistically significant. And I think this is what led the authors to conclude that it had something to do with anti-anaerobic effect, is that they did a secondary analysis of patients who received cefepime plus another anti-anaerobic coverage, so in this case, metronidazole, and this association of increased mortality held in those patients who received any anti-anaerobic coverage. The authors went on to then point out, because they were aware of the ACORN trial since this one came out later, why did the ACORN trial not show this increase in mortality in a randomized study? And what you can see here, so this is sort of the mortality curve over time. So percent alive on the y-axis and days out to 90 on the x-axis. You can see it takes more than 14 days for those lines to split. So they postulated that simply ACORN didn't go out far enough in order to detect the difference in mortality. Not so sure about that. So the conclusions, at least that the authors provide, is that Pip/Tazo and Vanco has a higher 90-day mortality in patients who show up with undifferentiated sepsis without a clear indication for anti-anaerobic coverage. But I think there's some strong limitations and a big asterisk by this data. So a single center, it was retrospective. I just don't know about this instrumental variable analysis. This seems kind of shocking to me that you would have such a large difference in mortality. And I tend to think that people who show up who are really sick are going to get the broadest coverage. And I don't even know that simply because there was a time of shortage, I still think the sicker patients may have still leaned towards getting vancomycin because Zosyn was still available. It was just in shortage. So I don't know. And the mechanism here, I think, I'm not so sure the mechanism is totally driven by anti-anaerobic coverage, but it is kind of interesting. And I think we ought to take knowledge of that. So final thoughts here, vancomycin, I think there's equivalent AKI risk. I don't think we need to worry about that so much at time of ordering. I would have some caution with cefepime and the neurotoxicity effects. So thinking about your patients who are elderly, frail, or have kidney dysfunction to begin with are the most likely to have this side effect. And then probably in my undifferentiated sepsis patient where I have pretty low concern, I still think probably less is more. We probably should be avoiding anaerobic coverage. We're not adding anything, and I think there probably is some harm there. Probably lean towards cefepime or another cephalosporin rather than an anti-anaerobe. But I think we need more data before we conclude that really mortality is higher in those patients. So I don't know that we've tipped the scales there. All right. So that's our antibiotic comparison. Let's move on to our next case. I call it 1.5 because it's still the same patient, but this is going to be talking about provoked AFib, and this is a individual provoking AFib in a heart. We'll call it getting into the rhythm. So case continued. So now you're the discharging provider. You're stepping in on the day this patient's supposed to discharge. They're new to you. You find out that actually the diagnosis ultimately ended up to being right lower extremity cellulitis, and appropriately antibiotics were de-escalated to cephalexin. But you read back and see that from your colleagues' notes, on hospital day 1, they had a several-minute run of atrial fibrillation with RVR. This EKG confirmed, but it was self-limited, and now they're back in normal sinus rhythm. They're currently on Lovenox BID, presumably for stroke prophylaxis. And now you need to decide whether or not you want to recommend further anticoagulation for this patient as they go out the door. Just as a reminder, because you may not have caught all the details to calculate your CHA2DS2-VASc score, they have diabetes, hypertension, and their age of 70. So they have a CHA2DS2-VASc score of 3. So which approach do you recommend for this patient? Do you recommend a DOAC? Do you not recommend a DOAC? Do you feel like you might need some more information to try to make an informed decision about what maybe their risk is? Or maybe you're still recommending warfarin to your patients. So I'll let you think about that for a second. All right. So the entity we're talking about and what this patient has is acute atrial fibrillation. So, or what we might call provoked, or we might call secondary. It's referred to by several different names. The background here is that it's actually pretty common, and most of us that work in the hospital see this not infrequently. But the data would suggest that up to 8 to 10% of our patients with sepsis, and actually a whopping 44% of our patients with septic shock, develop an episode of atrial fibrillation acutely. We do know from the literature that this does have a higher recurrence rate. So up to 33% of patients at 1 year will have another episode of atrial fibrillation. And we also know, extrapolating from our long-term AFib data, so patients who have AFib in the long-term future have a higher stroke risk, and this can be mitigated by anticoagulation. But we also know and have signals that provoked AFib is probably not the same clinical entity as long-term AFib. The absolute stroke risk may be lower. There's some observational data that would support that. These patients also in the hospital have more comorbid conditions that make us a little bit anxious sometimes to start anticoagulation right then and there. And also they're just getting out of a complicated hospitalization. So the idea of adding an additional high-risk medication can make us uncomfortable. And then finally, the clinical trials that approved these newer medications that we have, the DOACs, specifically excluded this population. So what do we do? Well, we could try to turn to our 2023 ACC AHA guidelines for atrial fibrillation. One of the things I want to remind folks is sort of what the cutoff is here for when we generally recommend anticoagulation. So the ACC AHA guidelines, it's a class 1 recommendation. So we strongly recommend anticoagulation to prevent the risk of stroke when that annual risk crosses is equal to or higher than 2%. And that means a CHA2DS2-VASc score of 2 in men and 3 in women. And then we say that anticoagulation is reasonable when the stroke risk is 1 to 2% per year. So what the CHA2DS2-VASc score essentially is doing is looking at the substrates, the sort of risk for stroke in people who have developed AFib, and then tries to give you an idea of when the benefit starts to outweigh the risks of these medications. And so just remember that 2% cutoff as we talk about this new article, which looked at the risk of stroke after newly diagnosed atrial fibrillation during hospitalization for other primary diagnoses. This was a retrospective multi-center study that was done in Canada between 2013 and 2023, so firmly in the DOAC era. Population was 20,000, a little over 20,000 patients, all older, above the age of 66. No prior history of AFib who were hospitalized for other causes. So our patient basically fits in this category. Who had a development of secondary or acute AFib during the course of their hospitalization. And then they looked at hospitalization for stroke at 1 year following discharge. They also looked at what the prescribing habits were as a secondary outcome. So did these people tend to get anticoagulation, and whether or not they were admitted for bleeding or had death at 1 year as well. So they interestingly broke the patients down into 4 different categories. And so they cohorted people relative to what their loose primary diagnosis was for why they're in the hospital. And they put them in these broad buckets of kind of non-cardiac medical reasons for their primary diagnosis, cardiac surgical, cardiac medical, and non-cardiac surgical. And the area I want to clue you into, this is a little hard graph to read, but you can see this red line right here. This is the cardiac medical. They stand out because their confidence interval for their, on the y-axis here is the percent cumulative risk of stroke. So this is the cumulative risk of stroke over the year. Their confidence interval was the highest, which is not surprising. Cardiac medical patients probably have the most substrate for AFib. So that was one of the things that they found as you broke these patients apart. But I want you to see that particular population. But I think more importantly, the thing that we're taught to do is to risk stratify people based upon their CHADS VASC score. And now in this particular study, they dropped the sex characteristics. So they just did the CHADS2 VA score. And what they found here was that actually the cumulative risk or cumulative incidence, I should say, of stroke was actually quite low in a population where we would ordinarily consider anticoagulating people. So if you had a CHADS VA score of 1 to 4, the cumulative risk over a year was only 0.7%. So not that high, and that's this green line here. Obviously, the CHADS VA score goes up to the 5 to 8 range. The risk goes up, but still 1.8%. And you'll remember that the class 1 recommendation comes at 2% or more. So what can we conclude? Well, one interesting thing, and I'm not showing you the data here, is that when they looked at prescriber habits, there was pretty much clinical equipoise here. So generally speaking, even in the highest risk cohorts, so cardiac medical patients, only about 50% of patients received a prescription for anticoagulation by 1 year. So we don't have a strong tendency to anticoagulate these people. The acute AFib stroke risk does appear to be lower than the chronic AFib stroke risk. So if you have a CHADS VA score of 1 to 4, the risk is really less than 1% in this population. But I would say that the cardiac medical or the CHADS2 VA score of 5 to 8, definitely those patients deserve more scrutiny. There are some limitations to this study, but I thought it was pretty well done. So one, there can be a misclassification of AFib, but I think that would tend to skew the results to a higher stroke risk. And the other one was that they did not make an adjustment for aspirin. So aspirin is somewhere in the mix here. We don't know exactly how that would have played out. But I think ultimately the conclusion here is that I think you can, for at least a lower CHADS VASC score of 1 to 4, you could probably safely send these patients out with close follow-up and to consider anticoagulation depending on further Holter monitor studies and other evaluation. All right, final case. This is one of hyponatremia. This is a SAD salt cube that ChatGPT gave me, but we'll call it buffing the lights. So here you have a 68-year-old female presents with hypertension, smoking, and is a prior smoker, admitted for shortness of breath and generalized weakness with a fall at home. Over their hospital course, they're diagnosed with small cell lung cancer, complicated by a moderate to severe hyponatremia. They're currently on a 1-liter fluid restriction, and they're also on salt tabs, 1 gram TID. Hopefully sounds familiar to those of us in the hospital, ways we try to manage these patients. However, now that you're coming on service, you see that over the last couple of days, unfortunately, their sodium trend is going the wrong way. So their sodium was 125, now down to 121. You see their urine osms there and their urine sodium, which is suggestive of SIADH. And other things have been ruled out with a normal TSH and an AM cortisol that was within normal limits. So question for you is, what do you do next here? You increase their salt tabs to 2 grams TID. you fluid restrict them and guarantee that you're going to get more pages by the nurses when the patient can only drink 500 ml a day? Do you give them a dose of Lasix? Do you increase their salt tabs and give them a dose of Lasix? Or do you start maybe something new, like oral urea? Or do you just sort of give up, consult your friendly nephrologist and ask them for help? So I'll let you kind of decide which of those you might want to do. All right, a little background on hyponatremia. So here's the definition. I'm not going to go into that too much detail, but hyponatremia is very common in the hospital. We all see this frequently, although usually it's not severe, but roughly a third of our patients that are hospitalized have it. We do know that it's associated with an increased length of stay, as well as cost and mortality for our patients. And roughly 25 to 40% of cases are actually attributed to SIADH, for which we don't really have great treatments for this entity other than trying to address the underlying etiology. But all the things we do not have actually very good evidence. So fluid restriction has shown to have pretty limited efficacy. You get a few point rise, but it's generally not ultimately that helpful. There's fairly limited data for salt tabs plus furosemide. There was this interesting study of fused fluid, which was a small randomized trial that compared these things together. So fluid restriction, salt tabs plus furosemide, and found that at 28 days, things pretty much regressed to the mean, that pretty much everyone had about the same increase in their serum sodium by about 4 or 5 points. So not dramatic. And then we have the Vaptans, which fortunately are expensive. They risk overcorrection, and it's always hard to know what to do with these medications as patients are getting ready to discharge. So what I wanted to talk to you a little bit about is something that's new and available to us, which is urea. Maybe convince you to try this as an option. So these come in packets. Urea works by causing osmotic diuresis. So by taking in a lot of urea, you're kind of delivering this more to the distal area of the nephron and increasing aquaresis. The body can no longer concentrate the water, and you lose more free water. It also decreases sodium excretion. I'm not exactly sure the mechanism for that. But there was a systematic review in 2023, which is where I became more aware of this medication, that said it was safe, effective, and inexpensive. It's been used actually more internationally and resource poor areas with some good effect. But the data has ultimately been limited. So what I wanted to review today was fresh off the press. This was published in March of 2025, so just this year, meta-analysis of the data that does exist. So 16 mostly retrospective studies. These were mostly small studies looking at a handful of patients, around 20 per study. But the intervention was urea for the treatment of hyponatremia. And the outcome they looked at was the mean difference, so the change in serum sodium concentration through the use of this medication. And a couple of the trials compared them to Vaptans and to fluid restriction, although I'm not going to get into that data because it was only a handful of the studies that did that. But what they showed here, and just to orient you, so the bottom here of the scale in this forest plot, so the bottom of the scale here is the mean difference, so the change in serum sodium. To the right would favor using urea. To the left would suggest that you're actually lowering their sodium with urea. And then they broke the studies that they analyzed or pooled together into whether they were studying mild SIADH, moderate SIADH, or severe SIADH. And what they found was pretty significant, I thought, in that, cumulatively across all the different severities, it had about a 9-point increase in the serum sodium, which is, I think, pretty good for if I could get most of my patients with, low serum sodiums in the low 120s up 9 points. That's a pretty good effect. And you can see it was most dramatic in patients with severe, not surprisingly. They had about an 18-point increase. So all looks pretty effective. The downside of this study, which the authors couldn't really explain, is there was substantial heterogeneity. So the I-squared test here, when they pooled all of them together, was 89%. So that's a lot of heterogeneity. That should make you question the results here a little bit. But fortunately, in all the studies, none of them showed any substantive safety concerns. So I think it's a relatively safe thing to try, but I think we need to question maybe how much of an effect this really has. So in conclusion, I think urea appears effective and safe. I think the biggest issue is its palatability that we saw, that it does not taste good. Although the N of 1 I've had in using this in the hospital, my patient didn't complain about the taste. So, but your results may vary. I would say though, and this is the thing that me and actually my residents, because we used this on one of our patients, had a thoughtful pause is when the order came up, and you can see here. So Providence by the order panel, when you order this, all these warnings pop up, and then they recommend every 6 hour serum sodium, which then starts making you wonder, what am I doing here? Is this really safe? The literature doesn't really support that. I think this is because it's relatively new. We actually didn't continue that because I don't want to poke my patient every 6 hours. I didn't think it was clinically indicated. Patient did fine. They did not have a sudden rocket up in their sodium. But anyway, all right. So with that, I will pivot to Dr. Moza. Sure.
You did not go over on time. I was impressed.
Well,
Full disclosure, my slides will have more color on them. I think that's a pediatric part of me, but let's get into case 3, chest pain, when to panic and when to pass the Tums. So you have a 42-year-old man with type 2 diabetes and hyperlipidemia coming in with a week of intermittent chest pain. It doesn't, not really sure if it's associated with exertion or not. Initial troponin negative, and your ER colleagues appropriately admit him out of concern for unstable angina and ongoing monitoring. You're the admitting doc and you're getting your history directly from the patient, and then the nurse pops in her head into the room, goes critical serial troponin of 4,000, and you're like, oh, not good. So you of course confirm that the patient is chest pain free, get an EKG, and you see some non-Etsy elevation in the anterior leads, and you promptly page cardiology. You're like, oh, it's 11:30 a.m. I wonder if they can squeeze in an angiogram today. They're usually really efficient. And you inform the cardiology team that the patient last stayed 4 hours ago. Can he safely undergo an angiogram this afternoon? No procedure. Why are you calling me? He already ate. Depends. Is the patient on Ozempic? Yeah, roll him in. So the reason that I presented this is because hunger never sits well with anybody, including our patients, and I'm always a fan of letting patients eat. And this trial, the calorie trial, was a randomized single center control trial where they took patients specifically going for cardiac cath procedures, and they divided them between NPO past midnight versus ad lib intake of liquids and solids, like basically whatever they wanted. They did exclude patients that were high risk for aspiration, so like patients with dementia, on opioids, chronic GI illnesses. And what they looked at for their primary outcome was an improvement in well-being score, which obviously while being improved, it was a self-reported score of hunger plus fatigue. But what was more interesting was that they didn't have a change in any secondary outcomes, which is rates of aspiration, changes in creatinine, or any hypo or hyperglycemia events. And the one thing cautionary on the ad lib protocol is that the average NPO times were 2.5 hours pre-procedure instead of 8 hours. So none of the patients were like eating a cheeseburger right while they were rolling into their cath. So they are still NPO for a little bit. And this past month, the Journal of Surgery also published this meta-analysis of randomized controlled trials and observational studies of 17 trials total, looking at the association of pre-procedural fasting and witness pulmonary aspiration. The biggest highlight for me is that there were only 11 aspiration events in the 2,000 plus charts that they reviewed in the RCT arm of this meta-analysis. So they didn't actually combine the analysis between the randomized control trials and the observational studies because the data that they looked at was a little bit different. The observational studies looked more at like clinical events of aspiration, and a lot of the randomized control trials looked at gastric volumes and pH and a little bit more of like the physiology behind aspiration. But when I saw the actual incidence of aspiration events, I'm like, oh, are we potentially starving our patients for too long? And they didn't show any statistical difference in the aspiration rates. Now, just as Michael alluded to statistical voodoo on one of his articles, this also had what I will call statistical voodoo that I did not fully comprehend and understand, just because there's a lot of variety of clinical settings and surgical indications that they looked at, from emergent surgery to holding tube feeds for an hour prior to trachs in the ICU versus elective like cardiac procedures. And so I think overall, what I anticipate with all of this is that hopefully the anesthesia guidelines may adjust from the 2017 guidelines, which are currently like NPO for liquids at minimum 4 hours. But our very own Dr. Mizgaski and Dr. Kimberly are working with our cardiology department to try to reduce our NPO times on our patients, which, as we all know, is always a good thing when we can feed our patients. So you convince the cardiology team that yes, his PO status should not increase his risk of aspiration. Your amazing cardiology team consults quickly and squeezes him in for an angiogram on the same day. You're like, this is amazing. He undergoes PCI to the LAD. A life is saved. They order an echo just to kind of evaluate his function. And you're doing your pre-rounds in the next morning, and you see that the echo was already done because the echo techs here are like ninjas and get them done so quickly. And it confirms the intact EF. So the next morning, he's like, I'm ready to go, doc. Feeling good, no chest pain, let's go. And you're going through his medications, and then he becomes stressed because he wasn't on any medications before. And he's like, are these all needed? So which medication is the least critical for the patient long term? Metoprolol, atorvastatin, aspirin, Plavix. Why is this a question? Please take all your medications. What is she about to talk about? So what I wanted to mention is that long-term beta blocker use is going to be actively studied over the next couple of years in the cardiology field, not in the hospital field, but just something to know that there's stuff coming on the horizon. There were three trials published in the past year. Two of these were in the past month, but the first one is the Beta-Me-Dan block. The second is the Reboot, and then last, the Reduce AMI trial. And what all three trials looked specifically at patients who have had a heart attack with an intact ejection fraction, putting them on a long-term beta blocker over a course of 3.5 to 4 years was the average follow-up period. Are we actually seeing improvement in mortality outcomes and major cardiovascular event outcomes? And the numbers of these studies are significant. It was like 5,000, 8,000, and 5,000. So these are pretty large populations that they're studying. What I do want to point out is that the countries that were included were European, one and New Zealand. And so the reason I like to look at that is because in the US, our time to revascularization is much quicker when you look at the average times. Like here at St. Vincent's, most of the cardiology team will get the angiogram done within 24 to 48 hours. Once they're like, okay, we have an NSTEMI or some reason for an angiogram. And the average time in these trials was around 3 to 5 days for revascularization, and I don't know if that has an impact when looking at generalizability. But in the Beta-Me-Dan block, that was the only long-term beta blocker therapy that showed a reduction in the risk of a primary endpoint, and this was mainly driven by a reduction in recurrent MI. In the Reboot trial and the Reduce AMI trial, they didn't show any difference between beta blocker versus no beta blocker. In the first two trials, they let clinicians kind of drive dosing, and in the Reduce AMI trial, they had target doses of 100 milligrams daily of metoprolol or 5 milligrams daily of bisoprolol. Bisoprolol was actually more heavily used, which again attests to the clinical differences of practice in different countries. And so again, that's why there's more studies to be done. As a visual person, I just wanted to show this. Basically, these are the graphs of the death from any cause over the years of follow-up. And you see that there's really overlap in the no beta blocker and beta blockers for the Reboot and Reduce AMI. And then the Beta-Me-Dan block one, you see how the lines diverge. And that trend is more prominent when they looked at the subgroup analysis of recurrent MI. The one article that I did not discuss because the setup was a little bit different was there was an ABYSS trial last year that looked at stopping beta blockers after 3 years out from an event, and that actually showed an increase in recurrent MI. And so I think with all of this like large trial data, the current 2025 ACS guidelines basically say there's more to be studied with long-term beta blocker. So obviously, at the end of the day, we'll defer to our cardiologists for right now, but just note that the landscape on beta blocker, long-term beta blocker data may be changing. In the short term and for hospital medicine, there's definitely utility and mortality benefit of giving beta blockers from the sense of decreasing the myocardial oxygen demand and reducing a risk of like fatal arrhythmias. And so just to distinguish it, this is more at the time of discharge. Are we putting our patients on the right medications? So you conclude with, please just take all your medications and talk with your cardiologist in your 4 to 6 week follow-up, but you successfully discharge the patient. He feels better knowing why he's taking all of his medications, and you head to your next admit of the day. Case 4, abdominal pain. It is a gut feeling. So you're the admitting doc. Actually, you're actually a triage doc because you're going to get the call. You've got a 47-year-old female with alcoholic cirrhosis presenting with abdominal pain and low-grade fevers meeting SIRS criteria. Your ER workup is notable for a lipase of 3,000. And so they appropriately diagnose her with pancreatitis. The ER practices the art of medicine and decides whether to call it sepsis versus saying that she meets SIRS criteria due to pancreatitis and abdominal pain. They decide on moderate IV fluid resuscitation, and you have a wonderful evidence-based discussion about all of this and admit the patient to manage her pancreatitis. And so the thing that I wanted to highlight in this part of the talk are the new ACOG guidelines for acute pancreatitis, which were released last spring of 2024. What I will say is that most of these are conditional recommendations with low quality evidence, primarily because they were either based off of pooled observational studies or single center RCTs. And so there's probably going to be more evidence coming through the pipeline over the next several years that'll either support or refute these things. But the highlights in the guidelines say, no longer do we recommend routine CT imaging just to assess pancreatitis severity, but we would do it if you're worried about complications of pancreatitis. I'm going to keep this a theme. I love feeding patients. So they say you can start with a solid low-fat diet, so no need to actually go from liquid to solid. You can just be like, eat what you can, start slow, but you can start with solids. LR is superior to normal saline in terms of resuscitation. Last year's Grand Rounds update in hospital medicine actually covered this topic, so I'm not going to belabor that point. We will talk a little bit more about the moderate fluid resuscitation strategy that is recommended for pancreatitis now. And then the last one is my favorite because I don't like things with lots of numbers and scoring, but they recommend that clinical judgment supersedes current severity scoring criterion. So like the Apache and the Ranson, I don't know if you guys remember like those like 12 lists of variables and you're kind of like, I don't know if this is going to help me clinically. So the guidelines explicitly acknowledge that and say, please use your clinical judgment. So what I wanted to go into more detail about was the waterfall study, which basically made the case for supporting moderate fluid resuscitation in acute pancreatitis. Since this was effectively a practice-changing thing for me, I kind of wanted to go into more detail about like, okay, well, what did the data actually show and what is this protocol? It was a multi-center randomized control, non-blinded study of 249 patients. I will go into why it was a lower number. But they looked at the primary outcome of development of moderately severe or severe pancreatitis. And the reason that's the primary outcome is because the initial theory behind aggressive fluid resuscitation came from animal models that showed that when there was hypoperfusion of the pancreas, it can lead to necrosis, and to reverse that hypoperfusion, aggressive fluid resuscitation is what prevented that. What they also looked at in this article was the safety outcome or development of fluid overload. And so in the primary outcome in the aggressive resuscitation group, 22% develops severe pancreatitis and 17% in the moderate resuscitation group developed severe pancreatitis. Basically no statistical difference between the two. But in the safety outcome, 20% of the patients developed fluid overload in the aggressively resuscitated cohort versus 6% in the moderate resuscitation. And that was a distinct statistical difference with a number needed to harm of 7. So the ethics committee actually met for this trial and they were like, okay, do we actually continue this study or not? And because the concern for harm was so great, they were like, we just need to stop the trial. And so that's why it actually ended up being 249 patients instead of their original like 800 that they were aiming for. The one thing that I will say is that they did exclude patients with electrolyte derangements, chronic renal failure, heart failure, and decompensated cirrhosis. All the hospitalists listening are probably chuckling a little bit because a lot of our patients with pancreatitis have a lot of these comorbidities. And so kind of keeping that in mind when you're approaching your fluid resuscitation strategies. And then I wanted to just go into the detail of what actually is the protocol that they studied. It basically looked at halving all the volumes. So instead of bolusing by 20 mLs per kilo, you only bolus by 10 ml per kilo. And then you do your continuous infusion at 1.5 ml per kilo per hour instead of 3. And then you do additional as needed boluses of 10 instead of 20. And then what I thought was interesting was actually the weaning protocol of when you decide to stop. For the moderate resuscitation, they stopped after consistent oral intake for 8 hours, but in the aggressive, they required it to be 12 hours. And then they also required in the aggressive protocol for there to be fluids running for at least 48 hours. You couldn't stop it sooner than that. And in the moderate, you could stop at as early as 20 hours. And so when I actually looked at the detail, I'm like, oh, is that potentially part of why we were causing more fluid overload in these patients? The actual median difference between the two arms was about 2 liters of fluid in the first 48 hours. And so again, these are all, I feel like when you look at studies a little bit high level, it's easy to be like, okay, yeah, this is great. But looking a little bit more in depth, there's really an art to deciding which patient meets the appropriate criteria for this kind of resuscitation protocol. So you're a hospitalist contemplating the discharge of this patient. She's eating, she's walking, she's afebrile. She's like, hey, can I go home? It's been 3 days. I want to go home. And you're like, oh, wait, the blood cultures grew E. coli on admission. Can I still discharge you? No, I want you to get IV antibiotics for a week. Yes, you can go home, but I want you to take oral antibiotics for 2 weeks. Nah, maybe you only need 1 week of antibiotics at home. Okay, I really need to consult an ID doc, somebody smarter than me. So what I wanted to talk about in this part of the case is antibiotic treatment of 7 versus 14 days in patients with bloodstream infections. This is the trial popularly called the BALANCE trial. It was actually I personally thought, a very well done study. It's a multi-center non-inferiority trial over 74 hospitals across 7 countries. And they were wanting to power this so well that they could prove a non-inferiority margin of 4%, with a primary outcome of a 90-day all-cause mortality. And so basically, patients who were admitted, and it was all patients in the hospital, ICU and like floor patients, they divided them between either 7 days or 14 days, and route of antibiotic and which antibiotic was completely deferred to clinician judgment, which I personally liked because it actually reflects how we practice medicine. And they follow these patients out for 3 months. And they basically showed that between the 7-day and the 14-day arm, the difference in the all-cause mortality was effectively only 2%, so 14.5% versus 16.1%. And that did meet statistical significance, and it was lower than their margin of 4%. Out of the bacteria that were grown, E. coli was the most common isolate. It was about nearly half of the cases, so about 45%. And what I wanted to point out in their secondary outcome analysis, because whenever we make decisions in medicine, we always think about, okay, if I make this decision, what am I missing on the other side? Like what am I potentially going to cause harm with? And what they looked at, and what our minds sometimes think about, is, okay, is the shorter course, are they going to relapse in their bacteremia? Are they going to get secondary infections or antibiotic resistant organisms if I'm giving them insufficient treatment? And then of course, our favorite risk of like C. diff, is there C. diff differences? And the rates really were the same between the 7-day and 14-day group. I was honestly surprised that there was still the same risk of C. diff infection between the 7 and 14-day group, but I guess once you're on antibiotics for that long, your risk has been predetermined. But it was well powered to kind of show that we're not really seeing any difference. And I feel like this really fits in with the current like cultural zeitgeist of shorter antibiotic durations and antimicrobial stewardship. The new pneumonia guidelines now say that you can get away with just 3 to 5 days of antibiotic treatment. And so I think this really fits in well with where the ID colleagues are trying to push us all to think. So you tell your patient, yay, you can go home. She's ecstatic. You're reviewing her medication list, and you notice that she's not on a non-selective beta blocker despite her prior EGD from a year ago demonstrating varices. After you appropriately determined that she didn't have any contraindications or problems of hypotension with being on beta blockers, you think about, all right, well, which one do I need to give you for primary prevention of variceal bleeding in cirrhosis? Propranolol, carvedilol, metoprolol. Okay, where did the attendee or attending go? So you're sitting there scratching your head being like, did the guidelines change? And so the AASLD actually put out new updated guidelines in 2024 on the management of portal hypertension. It was last updated in 2017, so it had been a couple of years. The recommendations in this practice guideline really puts carvedilol as your beta blocker of choice for prevention of bleeds. The data of this one was based off of a 2019 meta-analysis and several prior observational studies. And the idea is that the physiology of carvedilol, that additional alpha-1 antagonist property of that medication, really helps to decrease your portal pressures. And so that's kind of like the current recommendation. The trial that I wanted to talk about is a more clean, just like multi-center randomized control trial, simply because it answers that question a little bit more cleanly. So the Calibrate trial, this trial got published after the guidelines, but was actively being worked on during the guidelines being developed. And so they basically took patients who had never had a bleed before, but with known moderate to large varices, and they divided these 265 patients into either getting 12.5 milligrams daily of carvedilol versus variceal band ligation. And they follow these patients for a year out in terms of incidence of bleeding. And then between the two groups, there was 3.8% in carvedilol versus 7.6% in the variceal banding group. And when you initially look at that, you're like, oh, that looks like they should have found a difference, but it wasn't powered enough to show actual statistical differences of improved outcomes with carvedilol, but at least it showed that there was really no difference between the two outcomes. And there was also no differences in survival and complications of cirrhosis, which I think is important because by physiology, we're automatically thinking like, if I give you co-reg on a cirrhotic who's likely already running lower blood pressures, I'm going to cause a higher risk of hypotension. And they did look at that. I think the biggest drawback of this one was they had recruitment issues because it kind of overlapped with the pandemic. And then the guidelines got published, and then they kind of decided that they would stop the trial early related to this. So I'm hopeful that as the practice patterns and prescribing patterns change over the next couple of years, we get more robust data in regards to truly is co-reg more effective and the safety data behind that. So after an amazing day of evidence-based medicine, you leave the hospital victorious on the lives saved in the day. Thank you guys for following us through our day of rounding. Just wanted to bring it back to our learning objectives real quick. We hope you felt like we reviewed some recent clinical evidence and updated practice guidelines relevant to the field of hospital medicine. And for the primary care providers out there, understanding what practice management decisions that impact our discharging decisions of transition from hospital to home, whether it's anticoagulation, duration of antibiotics, or other medication choices. And then appraise the evidence presented within the construct of practice changing, practice affirming, and practice questioning. Originally, Michael and I had a slide where it divided all the trials by this, but then we realized that really the art of medicine is deciding that the person in front of you, do they meet the criteria of how you would apply this evidence to that person in front of you? Because at the end of the day, we all take care of different populations, and how we apply this evidence really has to be thoughtful. I'd like to give a final shout out to ChatGPT for all the photorealistic images of the hospitalists and the fun cartoons. No hospitals were harmed in the making of this presentation. And at this time, we'd like to open it up to the audience for questions.
Great, thanks so much. I'll see what questions we can get started with here in the room.
Roma, that was great. And Michael, so I was aware of the sort of shortened antibiotics for gram-negative bacteremia, and you mentioned that 50% were E. coli. Does that mean that there actually was some Staph aureus in the?
Sorry, I forgot to explicitly state it excluded Staph aureus bacteremia because that has a very different risk factor.
Yeah.
Thank you for reminding me that I did not say that in the presentation.
Thanks so much. It was a lot of learning. I have a question about in that last study, the co-reg at the once daily dosing. If I had seen that as a hospitalist, I would have been like, no, patient, you are taking this wrong. Co-reg is a BID drug.
Yes, I had to look twice. And indeed, in the guideline, it does say daily and not BID. I don't know why, which is why I said I think future studies are going to be important. I don't know if they thought that twice daily would increase risk of hypotension. It didn't allude to why they picked that dosing. So I don't know if it's increased risk of hypotension or you decrease the portal pressures appropriately. The studies that they had done from the guidelines that they looked at, like the physiologic studies and observational studies, all were studied with daily dosing. So I think it was just it kept growing from there.
Yeah, I'll add a question while others ponder. Going back to the section on acute or provoked atrial fibrillation, this is so common and often does end up involving decision-making by primary care physicians as well. I was just wondering what you see among your practice with regard to patients having extended monitoring ordered at discharge. Does that feel like that's sort of within the practice? Is there a spectrum?
Yeah, I would say certainly years with Zio patches being that I think common, certainly in the co-management with the cardiologist, I'm seeing. So I think it's easy enough, and I've actually even had patients with wearables come in, and that's actually how they got their second episode of AFib detected. So yes, I think that is. I've certainly done that more and more. Is to bring out with a have a work that would certainly suggest that their substrate is such that they're likely to have one. Yep. Yeah, I think the Zio patches are 21 days. Yep.
Great. Other questions here in the room?
We'll say the other thing that I think most of us are generally doing is getting an echocardiogram if a patient had one before, understanding if they have structural heart disease. That would also mention that, but that was sort of in the question of, do I want more information? My practice habit is echo.
Let's see. I have a comment from the audience, which may help feed into our initial question. So carvedilol is extensively hepatically metabolized, and half-life is prolonged in patients with liver dysfunction. So perhaps the once daily dosing of carvedilol makes a bit more sense to us. And apologies, I think maybe I'll have you lean into the microphone a little bit more just for the AFib answer, maybe just real brief repeat with regard to prolonged monitoring.
Sure, yeah. So in my practice habit is to generally send people out with an AFib monitor. I'm not going to anticoagulate them but I'm concerned that they're at higher risk for recurrence. I think it's very reasonable. They're not terribly expensive and they're fairly easy to do. I think the trick for us hospitals is just making sure someone is there to follow it up, and who that's going to be.
Great, thanks so much. And I'll just share another comment from one of our infectious disease specialists regarding the antibiotic oral duration. Said it would have been nice in the short antibiotic study if they advised highly bioavailable oral agents over, say, cephalexin or other beta-lactam antibiotics. I think this has been borne out in some other studies, really many patients on fluoroquinolones. Not sure if you have anything additional to add there, but thank you to our ID experts pointing that out. Great. We are nearly at the top of the order hour. Any last burning question? Okay, we'll finish on time. Thanks for your clarity of teaching.